for joining us today. Bom dia, boa tarde, boa noite, good morning, good afternoon, good evening. On behalf of the Radiology Society of Rio de Janeiro and OCAD, I want to welcome and thank you all. My name is Aline Serfari, and I'm here with Dr. Hilary Humans, who coordinates and moderates this series with me. Our guest speakers today are Dr. Ivan Godoy, Dr. N.K. Jazz, Dr. Diogo Edelmuth, and Dr. Felix Gonzalez. The presentations today will be recorded and available on demand on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiology Society of Rio de Janeiro. If you want to join the OCAD community, consider registering on the OCAD website. We will have a Q&A session. If you have questions at any time during the presentations, please put them in the chat box, and at the end, the speakers will respond to them. A quick reminder, attendees have not been given the permission to screen record any of these presentations, as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. We thank you for your understanding, and with that, I will kick off the session. It's my pleasure to introduce Dr. Diogo Edelmuth. He is a practicing MSK radiologist at Hospital das Clínicas of the University of São Paulo and at Sírio-Libanês and Albert Einstein hospitals. He graduated with a degree in medicine from the Pontifical Catholic University of São Paulo and completed his radiology residency and MSK fellowship at the University of São Paulo. His special interests include spine intervention and CSF liquid diagnosis and treatment. Please, Joe, share your screen.
Okay. And hearing me well?
Yeah.
Okay,
we
great.
can see.
Thanks to Dr. Vinicius. He's one of our current MSK fellows here at the University of São Paulo, and he has closely followed this case that I'm about to present. And he has also highly helped me in building this presentation, so thank you again, Vinicius. Some clinical background to my case. It's a 54-year-old male patient whose only past history is of a ischemic stroke 4 years prior to this, but without any long-term sequelae. He now complains of having fallen 2 weeks prior from standing height. He's complaining of pain on both his hips, mainly his right hip, and he's also unable to stand, and on physical examination, he shows limited range of motion. So a fracture is suspected and plain films are ordered on the emergency department. We can see clearly here on the plain films that there is this atypical, unusual pattern of both simultaneous, both subcapital and subtrochanteric diaphyseal proximal femur fracture. And the radiographs also show that this is a very clearly abnormal underlying bone. The cortex is very thin and the trabecula is very coarse, so it's an abnormally osteopenic bone. Further plain films show also that this pattern fracture is actually bilateral. We also see the same findings on the left side. And there are also other multiple fractures throughout his body. So this is clearly not a case of an acute event, but he has something going on for some time. Further CTs to better evaluate these fractures show that there are multifragmentary proximal femur fractures. There are also multiple fractures on the iliac wings, on pubic rami, and there are also fractures on bilateral acetabular fractures. Here you see the pubic rami better than on the radiographs. Pretty much all his vertebral bodies are fractured and to some extent compressed. There are sternal fractures, sacral body, and multiple rib fractures. So there's clearly some underlying bone disease going on, and further investigation was due. MRI was first ordered to exclude bone marrow replacing disorders. We see here that this is really just a disease of the mineralized bone. There are no signs of pathological tumor-related fractures. This is really just very osteopenic bone. And bone scans show mostly uptake on sites of degenerative joint disorders. There is some more focal and more extreme uptake on his right knee, but we'll get to that in a bit. So if we are dealing with a disease of the mineralized bone, lab values are mandatory and usually very elucidative. In this case, we had low blood phosphate levels and some increase in alkaline phosphatase. So we're dealing with some sort of phosphate depleting osteomalacia. After our colleagues, the endocrinologists, excluded most of the common causes such as chronic kidney disease, Fanconi disease, and inadequate intake, one of the suspicions was that of an oncogenic osteomalacia. This is a rare cause, but after excluding some of them are common ones, it needs to be excluded as well. This was performed by using a PET-CT with 68 gallium dotatate. That's a specific exam for some types of neuroendocrine tumors, and also happens to have uptake on this oncogenic osteomalacia, which is most commonly caused by phosphaturic mesenchymal tumor, albeit it's still rare, but most commonly caused by this type of phosphaturic mesenchymal tumor. So we see that little uptake on the bone scan previously shown was really just this small sclerotic nodule on the lateral condyle of his right femur. In this scenario, this exam was pretty much already diagnostic for a phosphaturic mesenchymal tumor, at least highly suspicious for it. A percutaneous biopsy could have been performed in this scenario, as this phosphaturic mesenchymal tumor. I'm sorry, just showing the MRI. Before anything, an MRI was ordered. It showed that there was not just sclerotic or coarse trabecular or anything related to the bone disorder, but it was actually a solid nodule inside his right femur. So we see here a solid nodule with enhancement post-gadolinium. And in this context, it was very suspicious for a phosphaturic mesenchymal tumor causing oncogenic malacia. As this tumor is usually benign, it may be malignant, but it is usually benign, and surgical excision, a curative surgical excision was proposed to this patient. They went right on to surgical excision and didn't perform any biopsies. The unfortunate part of going to surgery was not that it wasn't confirmed that this was in fact the diagnosis, a phosphaturic mesenchymal tumor, but as the lesion was very small, it wasn't really visible or easily visible under fluoroscopy. So the resection was performed based mainly on anatomical landmarks. They couldn't see the lesion directly. We see here the surgical cavity filled with bone cement, but the patient never went on to normalize his blood phosphate levels. Even 4 months post-operatively, we see that it did show some increase, but it never reached normal levels. So a residual tumor was suspected, and a new MRI showed clearly that there was a part of the tumor on the anterior part of the surgical margin that was really never resected. We see the bone cement filling the surgical cavity and some solid enhancing tumor right anterior to it. So at this point, they refer the patient to us to see if a percutaneous treatment was a possibility. And in this case, being a very small tumor, we thought that radiofrequency ablation would probably be enough and curative, most probably curative, because it was a small lesion. Our main advantage here was that we would use CT to guide the procedure, and the lesion was very easy to see under CT. So here we see the planning CT of our radiofrequency ablation and the radiofrequency needle or probe inside the lesion after we had made the hole for it. Technically speaking, this was a very simple procedure. We did the same protocol used for osteoid osteoma. So it was a thermal ablation at 90 degrees Celsius for 6 minutes. And we only did some hydrodissection here on the left lateral soft tissues to make sure the skin wasn't burned. It was pretty much the only organ here at risk for collateral damage. The rest was a very simple procedure. The patient, the procedure went fine. There were no procedure-related pain, no other immediate complication. And most notably and most fortunately, what we saw was the normalization of his blood phosphate levels. For academic purposes, we did an MRI right on the next day after the ablation, which showed that the entire tumor was hemorrhagic and necrotic, it showed spontaneously high signal intensity on T1 on pre-gadolinium and both on post-gadolinium images. And on subtraction, you see that there was no enhancing lesion anymore. As early as 2 weeks after the ablation, we saw a normalization of the blood phosphate levels. We are now at 6 months follow-up of this case. Blood phosphate levels are still normal, and all his main fractures have come to heal and consolidate. We can see that his underlying bone condition has not entirely normalized, maybe to some extent, but all his main fractures have healed, of course, with some residual deformity. So I have shown you a case of radiofrequency ablation, which probably most MSK radiologists are familiar with, but in a very rare, and I hope fascinating and interesting case of phosphaturic mesenchymal tumor in which we managed to salvage and cure a rare disease. Thank you very much. This is my contact, and I'm open for any questions even after we are over here. Thank you.
Thank you, Diego. That was really an amazing case. It's now my distinct pleasure to introduce Dr. MK Jesse, who is an associate professor of radiology and orthopedics at the University of Colorado Anschutz Medical Campus. MK studied at the University of Texas for medical school and residency and finished fellowship in musculoskeletal imaging and intervention at the University of Colorado Hospital in Aurora, Colorado. She currently serves as director of musculoskeletal and spine intervention with a focused diagnostic interest in hip and spine imaging. And on a personal note, she is a font of knowledge and useful information that has benefited both me and my mother, who is currently crumbling. And so I am very excited to learn from MK from her case. Thank you. MK, share your screen.
All right. Thank you so much, Hillary. It's my absolute honor to be in the company of such amazing radiologists and interventionalists. And I'm really excited to share this case today. This is a topic that's very near and dear to my heart. We do quite a bit of spine intervention at the University of Colorado, and particularly kyphoplasty and vertebroplasty. And I always talk to the residents and the trainees about kypho, and the technique. It's not rocket science. It's pretty easy, pretty straightforward. But where you run into issues is not understanding what complications can happen. So that's what I want to do today: share with you a case of a complication, with the hopes that that everybody can kind of recognize this and avoid it in the future. So my case is a 64-year-old male with a history of metastatic angiosarcoma. The original tumor was rising in the parietal scalp. That was treated, resected, and he was doing pretty well, but then he presented with new onset of mid-thoracic back pain. And you can see there's this destructive lesion within that T10 vertebral body. There's quite a bit of osteolysis going on. There's some involvement of that end plate. And there's also a superimposed pathologic fracture of that superior end plate. On the PET scan, you can clearly see that there is some active tumor here. There's uptake. So the assumption was made that his new back pain was largely related to the pathologic compression fracture that he had sustained over this lesion. So we were consulted as spine interventionalists to perform a stabilization procedure. Now, what we do in our institution is anytime that we have a patient who has underlying tumor, we go ahead and plan for a radiofrequency ablation of that tumor, just to try and prevent any late stage complications, any further tumor growth. Anybody who performs these procedures knows that the access and the technique is very similar between radiofrequency ablation and kyphoplasty. The exception is, or the only addition is the placement of these radiofrequency probes and the performing that radiofrequency ablation. So here's some of our intraoperative images in that T10 vertebral body. You can see our probes here using this bipedicular access. We placed two 20 millimeter probes, and we use an osteocool system where we can get up to a 3 by 2 centimeter burn around each of these probes. So it gives you a pretty nice coverage of that entire vertebral body. Just because we saw some increase in the amount of compression of this vertebral body, we decided to use a couple of different techniques for cavity creation to get the maximum fill of cement without getting into these tumor clefts and seeing this kind of abstract art that we often get with cement. So this is a curette. We use this to break up some of the trabeculus, some of the sclerosis, to improve cement flow. And then this, of course, is a balloon to make a craniocaudal cavity. So we use both of those devices. This was the fill that we achieved that we felt pretty good about. There's nice fill across the entirety of the vertebral body. There's nice fill craniocaudal. But one thing that you'll notice, and this will come into play later, is look at the margin of the cement. It's very, very smooth. I'm gonna come back to that point here in a minute. So the patient followed up in 2 weeks. That's our standard follow-up time. And he said he felt better, but then he started to have pain again. So we got the follow-up radiographs, and everybody, I'm sure, can see that there's a little bit even more compression around that cement bolus at that T10. But unfortunately, we have now an adjacent level fracture of that T9 with an increase in kyphosis across that lower thoracic spine. So because he had new pain, we have new fracture, we plan to take him back again and do a vertebroplasty of that T9 to try and help him out. Now, these are the intraoperative images. And I think maybe somebody has their microphone on. These are the intraoperative images in our second intervention. And the very important thing here is happening at this T10 vertebral body. Now look at the margin of this trabecula. It's actually right here. It's pulled away from the cement. This is a kind of bellows effect that happens when you have something called cement non-union. So we have this persistent fracture cleft. And when you have that persistent fracture cleft, you basically have a marble of cement that's rolling around in this cavity of fluid. And that's a real problem for a couple reasons. It can give you persistent pain, and it can lead to cement migration. So it was really imperative that we do our best to try to stabilize the cement bolus. That's what we can see here with this added cannula in that T10 vertebral body. Here's the fill that we got. So now you can clearly see, we can clearly see how large that cleft really was. So we tried to fill that as much as we could to get that positive pressure and try and keep this as stable as we could. Now, again, take a look at the margin of the cement at T10, how smooth that cement bolus is versus the trabeculated cement fill that we see in that T9. If you can get this fuzzy fill, which is what we call it, that is an inherent stabilization of that cement bolus. This is really what you're trying to achieve. But unfortunately, when you have these clefts, you get a lot of this look. So patient came in for routine 2-week follow-up. His history in that time was that he felt really, really good for about a week. And about a week after the procedure, he sustained a fall. Basically, he lost a chair, tried to sit down and the chair moved and fell straight on his tailbone. And then at that time, he had some return of his back pain. So we said, okay, well, let's just get imaging. Let's take a look. And this is what we got. So this was a major gasp when we got this imaging. This is about as terrifying a thing as you ever want to see. Hopefully everybody can see this cement bolus that we put in there has now watermelon seeded, basically squirted right out of that vertebral body and was lying in the anterior paraspinal soft tissues. We got a CT and showing kind of the same thing. You've got this persistent cleft, the migration of the cement bolus sitting in these anterior prevertebral soft tissues. So naturally, and of course, we consulted our spine colleagues and they went ahead and did a fusion for this patient. And he didn't have any longstanding complications from this. His pain improved after the fusion surgery. And we were lucky in that we were able to ultimately get him the relief that he needed. But I bring up this case to talk about a very important point for anybody who is reading spine imaging or anybody who's performing these procedures, and that is, what are clefts? So vertebral body clefts are this fluid or air-filled cleft within the vertebral body that happens in patients who are very osteoporotic. So what happens is that a very osteoporotic patient will have a compression fracture, and that end plate and the trabecula compress, but the end plate stays relatively intact where the trabecula compress. So you have this downward force that initially fractures, but when a patient lays down, that end plate pops open and you get all this fluid that pours into this potential space. And what that looks like on radiograph is, here you can kind of see this lucency through the vertebral bodies there. On the MRI, you can typically see these as fluid-filled areas, and there's that kind of bellows effect that you can imagine happening every time this patient is standing up and laying down. This patient had another cleft here lower down as well. So again, why is this an issue? Well, for one thing, it's a non-union, so the fracture is still mobile and it still leads to pain. That's obviously a terrible thing to happen, but cement non-union is really where you can run into major, sometimes catastrophic issues. And cement non-union is an absence of incorporation of the cement bolus within the vertebral body. There's no fibrous incorporation, there's no trabecular incorporation. It's truly just a ball of cement lying in an ocean of fluid. Typically, this is related to administration of cement into a large fluid-filled fracture cleft without adequate cancellous or trabecular filling. So again, this is where the margin of that cement comes into play. Whenever you see this smooth margin, just keep it in your mind that there is a potential risk of having a non-union complication. I'll tell you, it's often unavoidable, but it's something that we need to be aware of and follow appropriately. Again, by comparison here, the trabeculated fuzzy fill that we like to see in patients who have a more stable type of fill. On a CT, what we're looking for in cement non-union is a cement bolus with lucency. That's that fluid around the cement bolus with no kind of contact between that cement bolus and the adjacent cancellous bone. And then on MRI, this was a nice case of cement non-union where we see that dark cement centrally and then this rim of T2 signal all the way around that cement bolus. So why is it a problem? Well, we talked about this already. Obviously, this is our case here at the bottom, but persistent pain and cement migration. This is a case from the literature. It doesn't happen very much, so that's why I had someone from the literature, but this was a really interesting case where that cement bolus actually and unfortunately went posterior. And so you can see that cord compression related to that. So again, I show complications because I think they're the most high yield way to learn about interventions. I am happy to answer any kind of questions that you have. You can email me or we'll try and get to some of those at the end of the session. So thank you so much for your attention, and I will get back and unshare my screen here and let the next person start at.
Thank you, MK. Very beautiful case. Now it's my pleasure to introduce Dr. Ivan Godoy. He's a practicing MSK radiologist at HCOR, Hospital do Coração, Teleimagem, Alta, and Unifesp. He completed an MSK fellowship at the Santa Casa de Misericórdia de São Paulo and a research fellowship at the Massachusetts General Hospital. He's interested in all areas of MSK imaging with emphasis on sports imaging, intervention radiology, and artificial intelligence. He's very involved in MSK education and research, having authored and co-authored numerous original research and book chapters, as well as presented in several Brazilian and international conferences. He's a member of several radiology societies in Brazil and a member of the RSNA and the International Skeletal Society. Please, Ivan, share your screen. Yvonne, I don't think we can hear you. Can you hear him? I can't.
No.
Okay, and also it's not on presenter mode. Yeah, now it is. Great. But I can't hear you. You're muted. Yeah. I can't hear you.
All right. It was blocked. Right. So thank you, Aline and Dr. Hillary for the invitation for this presentation. So my case here, we have two cases that are related. This first case is a 44-year-old female patient with knee pain after a mild torsional trauma, and an MRI of the left knee was performed. And we have here a mild MCL sprain here, and also this mild bone edema, but without complete tears of the ligament. And also we have here this posterior soft tissue mass here near the popliteal fossa that measured almost 3.8 centimeters long, and with a diffuse and kind of heterogeneous enhancement on the post-gadolinium sequences. I read this case and I thought that it could be a giant cell tumor of the tendon sheath here near the popliteal fossa, or even a PVNS. So talk with the orthopedic surgeon that we could be done a follow-up imaging or even a ultrasound guided biopsy. So I performed this ultrasound guided biopsy here. We can see this posterior mass close to the posterior margin of the lateral femoral condyle here. Here you can see the popliteal artery here on the Doppler images as well. And here on this left below image here, you can see the needle inside this lesion. And I had no complication with this procedure. I used this 16 gauges and semi-automatic needle here, just exemplified as this image here. And here's the post-procedure imaging of the left of the left knee of this patient. So the biopsy result was in fact a giant tumor of the tendon sheath, and also the pigmented venolateral synovitis of the knee. Here is just a quick recap of my case. Here you have the posterior mass here in the knee, and also the MRI showing the same images. I preferred to do a medial to lateral approach here, because here we have the common fibular nerve near the fibular head here, so it's better for the ultrasound biopsy imaging to go from medial to lateral to get to this mass here. So 2 weeks later, the same orthopedic surgeon say, hey, I've got a similar case for you to biopsy. Would you take a look for this external MRI images? And so we have the 60-year-old female patient with knee pain, and a lateral meniscus tear was suspected. We did an MRI, and the lateral meniscus was in fact intact here. And we see this posterior soft tissue mass, quite similar as the previous case that I shown. It's quite as an elongated mass here in the posterior popliteal fossa of the knee. And here we had another images showing that this was in fact an elongated mass here in the posterior knee close to the popliteal fossa, and also a mild joint fluid here. And here we have this posterior mass here on the knee. I thought it was quite similar as the previous case, not as with that dark rim as this giant cell tumor that we saw before, but it's quite similar as the other case. And here we have the post-contrast images showing a diffuse enhancement here on the subtraction imaging as well. And here this posterior mass quite close to the other tumor that we had on the other case. So the orthopedic surgeon said, oh, let's do an ultrasound biopsy just like before. And I said, should we prefer this like more lateral approach here than the medial that I did before, because it was a little bit to the right here, to the external part of the knee. And he also thought it was a giant cell tumor or even a PVSN here of the knee. So I did an ultrasound guided biopsy just like the last case. And here we have this posterior mass on the knee. Here we have the posterior margin of the lateral tibial plateau. And here we have the needle inside the mass. And I've got 6 to 5 fragments of this lesion and sent to the laboratory analysis. And here we have a mild a mild vascularization of this mass on the ultrasound imagings, also with no bleeding and no complication. This tumor, in fact, it was quite a little harder than the other one, and the fragments would a little bit like whitish and not as bloody as the other fragment. And here we have this quick recap of this last case. We have this posterior mass here on the knee, close to the popliteal fossa and also to the popliteal artery and veins. And the biopsy was in fact a malignant tumor with extensive necrosis. And the result, you can see here we have some atypical cells with necrosis and this epithelioid aspect of this tumor, and was in fact an epithelioid sarcoma. So this case I brought you guys to see that soft tissue tumors around joints, and especially here in this case the knee, can be quite difficult to diagnose by imaging, and sometimes the biopsy is the best answer for us. And this epithelioid sarcoma was first described in the 1970s. Is a rare mesenchymal neoplasm, and it accounts for approximately 1% of soft tissue sarcomas, and usually presents as soft tissue nodules and masses, such as here on those cases here on the hand, these soft tissue masses here around tendon sheaths, and also some fascial nodules here. And we have usually 2 subtypes. The distal one, just as showed before, affecting the extremities, usually in young adults, associated with tendon sheets and aponeurosis. And also we have the proximal tumors, usually affect the trunk, armpits, groin, and also around larger joints such as the knee. As a rule, the more proximal, the worse the prognosis of those patients, and it can affect any region of the body, with reports of intra-articular involvement, such as our case in the knee. The treatment usually is perform a surgery with wide resection of the tumor and also radiotherapy, as chemotherapy is not usually a good choice for these tumors. Here we have our case. It was partially removed. Here you can see this soft tissue mass like a residual tumor here on the knee, and he's also doing a 6-month follow-up for about 1 year now, and the patient still with some mild pain here on the knee, but with no metastasis or no other tumors. And here we can see the literature. I was not the only one with this doubt about the differentiation between a giant cell tumor of the knee and this epithelioid sarcoma. Here we have the literature case showing this large soft tissue mass with some boundary structure here on the CT. And here we have on the right our case, and the histopathological examination was quite similar from the literature here on the left, and here our case on the right. And here we can see another case from the literature, this primary intra-articular epithelioid sarcoma with an unusual presentation of the knee, with this soft tissue mass here around the joint, inside close to the cruciate ligaments, and also to the suprapatellar recess here. With actually this patient went down to lower limb amputation. In this case, on the left is our case that I shown before. So my take-home message is imaging diagnosis of this soft tissue epithelioid sarcomas are quite challenging. Biopsy is mandatory when we suspect of a neoplasm around larger joints such as the knee. Follow-up imaging can be helpful, and we can see if there's a mass that is growing with bone destruction. We can then use these biopsies, but also always discuss with the surgeon with which is the preferred access point for eventual surgical procedures. We have to keep in mind that the surgeon is going to remove our biopsy trajectory for further treatment, and also keep in mind that we have to take as many fragments as possible for histological analysis. I usually take from 5 to 6 fragments for this analysis. And here, just a quick recap of our cases. Here we have this soft tissue mass around the knee that was in fact a benign tumor, a giant cell tumor of the tendon sheath here on the popliteal fossa. And here we have the other case, which is quite similar, but it was in fact this epithelioid sarcoma, very rare tumor around the knee. So future directions, maybe some help of some texture analysis or even AI could help us to differentiate between those similar tumors. Here we have this giant cell tumor with quite this black rim around it on T1 images. And here we have a more homogeneous tumor that was in fact this epithelioid sarcoma, which is quite, you can see this, it's quite more homogeneous signal as the other one. So this is what I have to show you guys. I'm opening for any discussion, any future questions. Thank you so much.
Ivan, thank you for that very scary case. I've only ever seen that tumor in the palm, and it looks, it usually looks really benign. Anyway, yeah. I'm moving on, and I now have the pleasure of introducing my friend Felix Gonzalez. Originally from Cuba, Dr. Gonzalez completed his undergraduate degree in chemistry from Kean University and medical training at Rutgers Robert Wood Johnson Medical School in New Jersey. He did radiology residency training at the University of Maryland and MSK fellowship training at Thomas Jefferson University. After his fellowship, he spent 5 years at Emory University as an assistant professor, where he introduced a new service line treating patients for advanced arthritis utilizing thermal ablative techniques. Recently, he relocated to Orlando to take a position with Advent Health Medical Group as an interventional MSK radiologist. And he's going to speak about his very interesting work on thermal ablation for treatment of symptomatic knee arthritis. Okay, take it away, Felix.
Thank you so much, Valerie, and thank you so much for this platform, for the invitation to present here today and be among so many stellar radiologists. I'm humbled. So basically, I'm going to start my presentation with a case that I got involved with a few years ago. It was a 66-year-old female patient that came in with left knee pain without any inciting trauma. The pain was located in the medial anterior aspect of the left knee. That got worse when she got up from a sitting position. She saw multiple orthopedics and she was treated with a single anesthetic corticosteroid injection in the joint. Unfortunately, she developed it was questionable whether or not it was an allergy, but it was definitely an adverse reaction to that injection, and she was deemed not to receive any more corticosteroid injections by her cardiologist. So she also had a DEXA scan that diagnosed her with osteoporosis with a t-value below -2.5. She had an MRI of the left knee that demonstrated a medial meniscal tear with extrusion and the classic findings of a subchondral insufficiency fracture. She basically went through multiple orthopaths and she was offered total knee replacement, but she wanted to do everything she could because she had other comorbidities such as diabetes and an elevated BMI that deemed her not candidate for a surgical candidate at that point. So this is her original MRI. You can see you can appreciate the peripheral extrusion of the medial meniscal body here that measure approximately 4 millimeters or so. There was a classic on the surface oblique meniscal flat tear, non-displaced, and this insufficiency fracture was very small. You can actually see it over here. So subchondral insufficiency fractures are usually seen as a T1 dark line, and then on the fluid sensitive sequence, you will see edema-like mirror changes. She was very symptomatic here. You can see the paraligamentous edema surrounding the MCL fibers that were deep and superficial to the ligament. So the issue with her was that she couldn't receive any more, corticosteroid injections. So she was looking to have some pain relief. So I treated her with Kulev. This is a 3-needle approach targeting the respective genicular nerves around the knee. Usually the nerves that we treat are enumerated here as 1, 2, 3, and 4. And this basically the different names of the genicular nerves. The treatment is utilizing full rear frequency ablation, and each side is treated for 2.5 minutes at its set temperature of 60 degrees Celsius. So afterwards, she experienced pain relief for within 2 weeks, immediately within 2 weeks after the ablation, that persisted for 6 months afterwards. We put her on a high dose of vitamin D, 20,000 international units for 4 months in preparation for the bisphosphonate therapy. And she underwent 2 infusions of bisphosphonate 8 weeks apart. She was restricted to touchdown weight bearing for 3 months following the procedure. And then she went on to be advanced into physical therapy to recover her range of motion. At 8 weeks follow-up, she denied pain entirely. She was pain-free at rest, but they had some slight discomfort with limited activity. We performed an MRI approximately 4.5 months after the ablation technique, and that showed complete resolution of the marrow edema, as you can see here. By the way, in this MRI, there was you can appreciate that the extrusion of the manipulus was a little bit more, but that was not relevant to her pain at all. She didn't have any restricted range of motion or with a pain-free state. So this is how she did over time. Cruz, Womack, and VAS score. She went from 9 out of 10 extreme pain down to no pain at 6 months, with improvement of the functional functional status over time. So you all know how traditionally, we all know, right, the consequences of chronic pain and arthritis. That how many, it involves about 30 million people. 10 million of those people presented with symptomatic knee OA. It's really a problem. And one way that we treat this discomfort and pain in patients with advanced OA is by utilizing opioids. And just the data says how horrific some of the patients do right after they get addicted to opioids. Every time I do these presentations, I always struck by these statistics that even though the U.S. only makes up 5% of the world population, we consume approximately 80% of the world prescription opioid drugs. So quite the problem we have here. So this is almost, about 116 patients die every day from opioid-related drug overdoses. Somebody I heard a presentation once that said it's almost like having a plane crash every single day and everyone inside dies. It's quite a big problem. So, the algorithm that we have to treat knee arthritis is basically fragmented into short lasting pain relieving lasting techniques such as physical therapy, weight loss, and NSAIDs. And you have the injections, right? Arena where you have the corticosteroid injection, the viscous implementation, the biologics. And then on the other side, we have a knee replacement that leads to more longer lasting pain relief. Unfortunately, the data says that only 35% of all patients receive a total knee arthroplasty, with most patients lingering among the other ways of treating knee pain that only leads to short pain relief. So if you look at the American Academy of Orthopedic Surgery, what they recommend, so the recommendation is inconclusive for the use of opioids, acetaminophen, pain patches to treat symptomatic knee OA, inconclusive recommendation for the use of corticosteroid injections. Specifically, they don't have a very targeted recommendation for this problem, which affects so many patients. So this has left me wondering for many years. Unfortunately, the corticosteroid injection, right? We've seen the papers coming through in the past few years, questioning how are we doing actually something good for patients, injecting them with corticosteroid injections, and the complication that we can have, such as progression of OA and even collapse of surfaces like the humeral head, for example. Here's a radiology landmark paper questioning how safe these injections are. This is within that paper. You can see this patient that received the knee injection with corticosteroid went on to have a subchondral fracture and collapse and progression of that medial knee compartment away. So one way that we can treat this is through neurolysis, disconnecting that pain being transmitted to our brain. You can do this in multiple ways. One way to do this is by a variable frequency, a thermoablative technique. And basically, the utility of cool variable frequency ablation is that we have a larger treatment zone at the tip of the needle than the traditional standard variable frequency technique that we have, accomplishing about 5 times the lesion size. And the reason why this is important is because I always show this, right? This is a rendering of the nerve anatomic courses of 27 patient cadavers, just to show how much variability there is through the anatomic portions of the genicular nerve. So if you were to utilize the standard variable frequency ablation, you will only get a portion of this probable courses. What you want to do, you have a very wide ablative zone that you can capture as many nerve variations that you can, increasing the accuracy of your technique. These are the multiple sites that we can utilize that have been described in the literature about the need to treat knee OA. These are the 4 classic sites that we utilize. This is a nice case report. So you can actually see some of that, the bone, like if the needle is close to the bone. This is actually the footprint of that burn onto the bone and the how much of a water zone you get with this technique. This is a very nice paper, basically, where they say, well, we utilize fluoroscopy for this procedure, and how do we know that we actually treating the correct zone, the correct areas? This is an MRI showing that if you actually create tangents along the cortices, the metaphyseal and the epiphyseal cortices where they intersect, if you put a needle there in fluoroscopy, you get 92% of the superolateral genicular nerve, about 88% of the supermedial, and 100% of the time you get the inframedial genicular nerve. So quite accurate if you follow that crossing point on fluoroscopy like here. So basically how we do this is we bring the patient in, we do an anesthetic genicular nerve blocks first, and the patient have more than 50% pain reduction sometime in the future. It doesn't have to be 1 to 2 weeks later, just based on your availability, what you practice, the patient comes back and get the full frequency ablation, and then we'll follow those patients over time in the office or through the phone. These are the different nerves, anatomic courses about the knee. So the patient comes in, we do the nerve block, we inject one, usually one. I'll say 1 to 2 cc, but you'll want to use the least amount of lidocaine volume that you can just to localize the nerve exactly in that area, not to inject too much that lidocaine will percolate through space and then you don't know exactly where the nerve is. And then 15 minutes later, you examine the patient. If you have more than 50% pain reduction, that qualifies the patient to get the ablation. So this is something that I searched in the literature recently, just to see. Some people have said, well, those genicular nerve blocks, with lidocaines, what if you add corticosteroid? Does that make a difference? And throughout, if you look at the literature, there isn't a lot of literature on that. Initially, there was a paper that came out by Kim a few years ago saying that, no, it doesn't make a difference, that they injected, lidocaine with corticosteroid in 3 different areas and didn't make any difference. But recently, another paper came back basically saying, if you increase the concentration of the corticosteroid, these patients will actually achieve as much pain relief as cool refrigerated ablation, which is quite, the transformational paper here to see perhaps just doing nerve blocks, we can get away without doing cool refrigerated ablation. That have to be researched further for us to know that. So I'm just gonna kind of go through quickly here. So you have either the option to do 3 needles or 4 needle approach. So this is the 3 needle here, the 4 needle, just adding an extra needle superior to the patella pole here superiorly. This is the what your apparatus will look like. Here's the introducer. This is the RFA probe, and this is what the machine looks like. The more modern version of this machine looks even cooler than this. So what you do is you sedate the patients with constant sedation. You numb the skin. You introduce the stimulation introducer into those respective areas, and then you add an RFA probe that are 4 millimeters, have 4 millimeter out the tip. And then you ablate for 2.5 minutes. But first, you check for motor nerve activity to make sure that you're not burning a motor nerve. And then you basically do that. This is a very quick paper that I did when I was at Emory. We treated comparing 3 versus 4 needles patients and followed them up to 6 months. And basically, what we found was that most patients had received at least 2 injections of corticosteroids before they came to us. And they were having basically pain between 2 and 3 years before they came for treatment. These patients had significant pain relief. As you can see here, 82% of them have 50% or more reduction of pain. The one thing that we saw, which is still, I'm trying to understand this, is that for the nerve block itself, just a pure lidocaine, once you see lidocaine in each of these respective places, the patients reported back that they got it between 2 and 3 weeks of pain relief just by doing that by itself. So you can imagine how much you can utilize that for, right? So we do a nerve block before they do a total knee replacement. A lot of research has to be done in this area. So this is basically the coups, how they did over time. So this is the baseline, and as you can see how much improved in function and pain they had over time. Walmart is the same, shows the same as well. The VAS score did, they did really well. They started at 8.4 down to 3.3. And you can see basically over time, 2 weeks, this is baseline here, the blue color. And then the 3 and 4 needle, you can see how much substantial improvement they had. Utilizing Woods and Walmart at 2 weeks. At 1 month, it was the same drastic improvement. You can see how the 3 and 4 needles didn't have really that much significant difference between those 2 approaches. However, over time, at 3 months, now you can start seeing how the needle was tilting towards the 4 needle being a better approach and leading to more pain relief. You can, in that 6 months, even more, you can see the difference now between the 3 and 4 needle approaches. For the medication, we also went back and looked at how much impact it made in the opioid medication usage, and you can see how overall there was a 65% reduction of consumption of these medications, but the big difference was seen with patients treated with 4 needles versus 3 needles. You can see 80% of them had basically they consume a lot less opioids or stop altogether, and there was no significant difference in the 3 needle patients treated with 3 needles. This is all the papers that on this, on this research. Not that doesn't belong to me. Just multiple authors have detailed durations of pain relief up to 24 months after utilizing full refrigerated ablation. We also have published papers utilizing the same technique in the shoulder to treat shoulder 08 as well. We published a first pilot paper on this topic with 11 patients about 6 months ago on Sociedade Radiology journal. Targeting the respective nerves around the shoulder. There's a very graphic paper that detailed this technique that was also published this past year. We also took it to the hip as well, treating the respective nerves around the hip with great success as well. And we published the first pilot paper on the Sociedade Radiology of this topic. Thank you so much for the invitation, and I'm open to any questions.
That was amazing, Felix. Eleni, I'm going to jump in and ask a question. My question is for MK. I'm just finding it. Basically, I can't find it, but I'm concerned about adjacent level fractures. I'm concerned about adjacent level fractures, and I mean, it seems like whenever you put cement in a vertebral body, you're going to change the stress at the interface between an unfractured osteoporotic vertebra and now a rock hard vertebra. Is it is the risk of adjacent level fracture simply based on the severity of the osteoporosis? Does the risk vary with location, whether it's thoracolumbar junction or elsewhere? And then specifically, since this was relevant to my own personal family, if you have skip levels, and let's say, for argument's sake, T11 and L1, would you just treat the affected levels? Or, I mean, it seems like there's an incredible risk of the normal intervening level. Would you treat that prophylactically? Is that done? Are you allowed to do that?
Yeah,
Discuss.
absolutely. Absolutely. So, so adjacent level fracture has been a point of research, of question for a long time. And to your initial point, there have been actually some pretty good biomechanical studies that looked at what the force across a disc is when you have cement in a vertebral body. And according to those studies, there isn't any increased force transfer across the disc to the adjacent if it stays within the confines of the vertebral body. Now, all of that being said, when you have a fracture, so in real world applications, you're dealing with this constellation of different risks. So you've got patients who have proven that their bone density is low. If they have multiple fractures, they're going to be have up to 70 times increased risk of fracturing over the same age patient who doesn't have any fractures. And that's probably just a testament to their bone density. We know that adjacent level fracture risk increases with increased kyphosis, with location at the thoracolumbar junction, with the presence of disc extravasation, where you're kind of throwing those biomechanics out the window, because now you actually do have that rock hard cement right next to the vertebral body. Also, to your other point, pincer bodies, sandwich bodies, skip levels, all those are names for an intact vertebral body between two fractured levels. And we know that those pincer bodies have it's really actually a quite profound increased risk of adjacent level fracture. I think some papers are up to like 20 times. And it may not be necessarily the presence of cement above or below. It might be that they already have two fractures. We've got kyphosis. We're at the thoracolumbar junction. All those things together are saying this is a super high risk level. So to your last question, which is, what do we do about these levels that we know, these adjacent levels we know are going to be increased risk? Generally speaking, everybody's got a 20% risk of adjacent level fracture. You take all these other things together and that risk starts going up and up. So what we do at our institution is take a look at the whole picture and say, how many of these things, can we add to their general risk of fracture? We also consider the age of the patient, their anesthesia risk. Do we want to put this patient under again? So all those things together might direct us to actually prophylactically treating an adjacent level. The really important point here, though, is right now in the US, it's not something that we can bill for. So you can't bill for a prophylactic level. So it has to be a no bill. That's what limits people from doing it, in my opinion, because the data is just so robust that it is so high risk. It's that it doesn't get reimbursed. So you have to kind of make a big effort in your verbiage in the report that this is not going to be a billed level. And you can probably do that until the administration tells you that you can't, and they haven't told me yet. So I feel it's the right thing to do. But it's a really complex, multifactorial thing that leads to adjacent level fracture. And then your last question on if medication helps. The only thing that has been
I don't know. Excuse me. I didn't repeat that. I asked whether.
Oh, sorry.
Hold on. Let me add the question. If somebody already has these vertebral compressions, is it helpful at all to institute therapy, medical therapy for osteoporosis, or is there no real benefit to that? Okay. That's
yeah, absolutely. So what we do is we have our patients go into a dual clinic and they see endocrinology, because you've got basically two different things that you can do. You can prevent further bone loss, and that's where your bisphosphonates come in, your vitamin D supplementations come in. There's only one medication right now, and class of medication, that will actually build back bone, and that's Forteo or teriparatide. That has been shown to decrease risk of fracture slightly, but it's a rough medication. It's an injection that they have to come in and get routinely. Patients don't like it. So what we generally say is, if a patient is relatively young, maybe in their 60s, even 70s, where we can potentially prevent some significant or relatively benign type of medication that halts further bone loss, that's reasonable. A lot of our patients, though, are very elderly, in their 90s. Those patients you might, we're a little bit less concerned about, because we're not as concerned with future bone loss. And we don't typically put those patients on such a intense medication as teriparatide. But this is, I think, an area where we've got a lot of room to improve on, what's the best for the patient. So there's a long answer to your question. Sorry about that.
Jesse, I actually had a quick question. I heard people that I'm actually started to treat people with lytic metastatic disease and doing percutaneous cementoplasty, not in the spine, but peripherally. And I heard, as I learned about this technique, some people say that they actually look for a little bit of fragilization of the cement into the adjacent space, just to make sure that they cover the entire space that you're treating. Do you actually try to prevent that in the spine? You don't want any fragilization. How do you know that you're not treating the area that you injected cement into?
Well, yeah, I think generally we try to avoid it. When you're dealing with metastatic disease, it's a little bit, I kind of tell the trainee, it's kind of a non-issue, because they're not fracturing because of low bone density. So those risks of extravasation, the pincer body, things like this might not really apply. So I can say that I'm less worried about it. I don't know that I push it to that point necessarily. I more use the percentage of craniocaudal fill and then the percentage of AP fill to show that I've stabilized, and then we use radiofrequency to try and get like the actual tumor coverage. I know some people will use the cement and the thermal effects of the cement to actually perform ablative treatment to a tumor, and I think that makes sense, but it's not something that we typically will do, but we're definitely way less worried about it in that patient population.
Thank you.
Okay, there is 2 more questions here at the chat box from Alihari Lighty. Excellent case. It's for Diogo. How does the pathology of this tumor differ from a giant cell tumor?
To be quite frank, I wish I knew that much pathology. I think if I did, I'd be promoted to pathology. But what I do know is that the clinical scenario will be very different, and there's also I'm not sure if it's routinely used, but we do have the fibroblasts. The 23 FGF, that's a growth factor for fibroblasts, and it can be dosed on the blood. And I have just quickly Googled it here. You can also do stains on it on the pathology, but I'm not even sure if that was used in our case. Our pathologists are very direct when they are sure of the diagnosis. I'm sorry, that's not good. Okay. Our pathologists are very direct.
Can everybody else turn off their audio? There's some noise. Sorry.
Yeah, sorry. So in our pathology report, you just said phosphaturic mesenchymal tumor. They were very clear about it, that there were not any doubts, but they also had access to all our clinical information as well. So I guess maybe stains could answer the question, but the entire scenario is very suggestive of it.
Thank you. There's also a question for Felix. Hillary.
Oh, Felix, I had, like a multi-part question. I typed the question before you finished your presentation. So I see that you just do the nerve testing to make sure you're not cooking the motor nerves, but in terms of the sensory nerves, it's just probe placement and that's it, correct?
Yeah, so actually that science is evolving as we speak. So the previous cadaveric studies have shown the anatomic courses of the genicular nerve, or some people say geniculate, as I'm learning more into the field. So basically, they say that you want to be on the AP position. You want to basically be in that metaphyseal flare, the deepest portion of that valley. And on the AP, you want to be approximately 1 to 2 millimeters away from bone. You don't want to be right on top of the bone. And then on the lateral view, you want to cover at least 60% of the AP dimension of the bone. And that's comes basically from cadaveric studies. The genicular nerve, the trunk of the genicular nerve before they branch into sub-branches, they actually form anatomically very posteriorly, the second half of the femur. So there's actually a couple of papers now that came out in the past, I would say 3 months or so, that they're actually saying it's even more posterior to that. They basically show on cadavers that the anatomic courses of the trunk of the genicular nerves are even more posteriorly, just right in the posterior cortex of the femur. And they show, they ablate actually the RFAs, and they show that the nerves are actually even more posteriorly. So basically what we do the AP, proper position of the needle, and then we turn on the lateral view, and the tip of the needle will have to be at least 60% deep from anterior to posterior dimension.
Okay, a couple of more quick questions because I might have to run, and don't hate me if I have to run. 2 more questions. I think the elephant in the room for everybody in their own mind is, aren't you creating neuropathic joints? Isn't that a problem? I know you do lots and lots of these, so I'm sure you have the answer that we all want to know. And then I'm wondering, okay, I'm back. Are orthopedists and sports medicine and pain management non-radiologists taking this procedure and running with it? Okay, tell us.
Yes, so basically neuropathic joint, that's probably one of the most common questions that I get in different meetings. And that's, it's a valid question, right? Are we creating a problem by trying to solve another one? And I remember, I never forget, when I first started this, right, I said, well, what are they, I'm a calculated risk taker. So I say, this is a cool procedure where, a low profile for complications. So the first thing I did was I contacted Dr. Resnick, not to put him on the spot. I said, have you ever heard of any intervention in the knee or large joint that has led to neuropathic joint? And he basically just went down, I think there was only one case reported ever in the literature of a neuropathic process in the knee, not in the foot, in the knee. And it was someone with that had hemophilia, and it was a complication of multiple, internal bleeding. So basically, as I studied try to understand what shortcut actually means, it's a sensory motor dysfunction, right? So you lose sensory, and you also lose motor function as well. So that's why you see traditionally the atrophic hypertrophic bone loss in the foot, right? You have disorganized bone loss with disorganized bone formation. So you literally have to lose both the motor and the sensory intervention to that joint. So for us, that's why we do the motor test, make sure that, that we're not selecting any motor neurons for treatment. to make sure that only the sensory, the deep sensory, and we only affecting the deep sensory innervation. Like they don't lose sensation on top of the skin. None of that is affected here because that's innervated by different sets of nerves. For example, we see the nerves like I'm blanking out right now, but more superficial nerves. So basically, I treated at Emory when I left. My count was almost 5,000 patients treated, and I had never saw someone that came back with neuropathic joint. And the other question that I get is like, hey, don't you think that people will have their knee OA accelerated? Like they don't feel any pain, so they're gonna go and run, a marathon, and then now they're gonna really end up with a worse state that they were before. And the question is that
can somebody who is giving us the audio interference turn off your speaker? Thanks, Felix.
Yeah. So basically, we have to take a step back and say, who are we actually treating? We're treating with patients with moderate to severe arthritis that have no other options, right? These are patients that have gone to the orthopath and said, I need one in TKA, and their orthopath have said, well, listen, you don't qualify because your BMI is very high. You have cardiorespiratory, comorbidities that make you a high risk for surgical, intervention. This is the last resort that these patients have. This is the, it's almost like when you drive, you see the dead end. Basically, this is their dead end, solution for the issues. So what I've had is before COVID, I had with a local YMCA gym where I would treat this patient for knee OA and then basically link them to that program where they will lose weight and then be at a much better physical state to either not have surgery or undergo the surgery safely. I say that the best program that I saw, now that I'm promoting one or the other, is aquatics, where the patient got the two total TK leaf, and then they went on to do aquatics exercise. So those are the patients that did the best and the most weight in a short period of time, within 3 months or so after leaf.
Personally, I have to say your work is, I think, amazing. The complications and risks of chronic pain medication are enormous. I'm personally dealing with that, and it's just fantastic what you do for these people. Thank you.
Thank you.
Okay, I'm out.
Thank you. Nice to see you.
Thank you all for joining us today. Next session will be on sports imaging. See you next month. Bye-bye.